already started going over this, right? This idea of differential diagnosis. So, pulmonary or upper respiratory stuff comes in, depending on where you're at, you start creating your differential diagnosis. All right, that's going to kind of change if you're in an ER versus urgent care versus primary care clinic, in the field, whatever. So high mortality emergency, what are some examples of that? What's that? What would be like some examples of high mortality emergent pulmonary stuff? Top of your head. Pulmonary edema, right? Edema is more like a symptom, but yeah, it could be. High morbidity. COPD. Right? PE is more of like high mortality, right? If you don't diagnose that pulmonary embolism, like sooner than later, they're going to die. What about pneumonia? Right? It's probably not going to kill them right now, but if you're just like, all right, let's give them 3 to 5 days and come back, and then families bring them in a wheelchair, morbidity, right? It's going to kill them in days. Common being common, what? Less emergent. People don't like that diagnosis. Yeah. What else? The flu, right? A number of things. Any type of nondescript URIs, less common. These common zeros. Now we start getting to that stuff where you've ruled out everything else, you've run every test, it's not getting better. That's where you go. Psychosomatic, what is that? Yeah, it's very easy. So I will say, especially towards the end of my Army career, those last two, as soon as I came, very jaded. I'm not going to be honest with you, right? You get cynical about stuff, and you think everybody's in for secondary gain. Psychosomatic, the guy's crazy, this lady's crazy. So don't be like that. Treat everybody with dignity and respect. At least give them the chance to hear out. And then you rule out everything else, and they're asymptomatic in front of you. Then you can go down the lingering path. And I'll say 16 years as an Army PA or 15 years Army PA. One time was I actually ever able to get the lingering actually proven and got somebody UCMJ. Another way it was the company commander, first sergeant, saw the guy who was going to a med ward for shoulder pain at the country club at Fort Hood, lift up a girl like Dirty Dancing, like spin her around. They took the video to JAG. That company commander, first sergeant, like heroes across Fort Hood. So let's say actually got it and everything. And these guys they're awesome. Alright, so overview, these are the main ones that we're going to talk about. Cough, shortness of breath, you're going to see these multiple times a week. Coughing up blood, less likely. The majority of the time it's not actually truly coughing up blood, it's something else. Chest pain you see a good amount just because of the military population. But the first two are really going to be what we're our bread and butter. Key to determining underlying cause, is it actually pulmonary or is it secondary, right? Is it postnasal drip, is it GERD, something else going on? Do they have an injury that's affecting their breathing, or is it actually the lungs themselves? With cough. I have a good story about this. So years ago I was working here as an instructor at 60 Whiskey, and I had to work at the McWorthy TMC. And I had a sailor come in one day, and with a straight face, I talked to this guy for like 30 minutes, not once did he cough the entire time. And I spoke with the medic that was out like in the triage area. I was like, "Has this guy coughed once?" And he's like, "No." The guy comes in there and he's like, "I need purple drink." I was like, "Purple drink?" He's like, "Yeah, drink." I was like, "Is that D-R-A-N-K or I-N-K?" He's like, "Drink." I was like, "Right on, man." So he didn't cough. So you have kind of like two scenarios where you can go with this. You can just be like a hard ass and say, "No, get out. You're just drug seeking," or you can kind of have fun, start your day out correctly. So, right, I had fun with it, but it's a good way to kind of like not have your patient leave upset because it shows that you care, you tried. I was like, well, hey, let's look that up. So I'm like putting it into CHCS, or all of a sudden I'm looking up purple drink. I was like, it's D-R-A-A-N-K, right? He's like, sure. So I'm looking up, like, purple drink's not in there. We call it pharmacist. Pharmacist was like a retired Army guy that was very angry all the time. Had bad, poor life decisions, didn't like his job. And I was like, hey, Ed, do we have purple drink? He's like, I don't got time for scrap, Anthony. We know what that is. But the patient's hearing me say all this the entire time, right? So in his mind, he's like, well, this guy's going to bat for me, man. He's actually doing the legwork. Meanwhile, the guy's never going to get purple But I was like, hey man, I'm sorry, we just don't have it on formulary. Maybe go to another clinic or try it out. He's like, well, I appreciate it, sir. He left happy. I had a good story to tell. Right? So you don't always have to be a hard ass with every patient. You can kind of have fun with it, go through the motions, make them seem like you care, and discharge them. Right, so cough, we kind of break it up into two main groups. You can also look at a third group, so acute versus chronic, and then you have that subacute. So coughing is a normal protective measure. We're trying to clear stuff out of the airway. What are things that can impede our ability to cough, to actually clear those secretions? Smoking, right? Smoking destroys the cilia. What else? What is everybody doing nowadays? Vaping. Yeah, so they're vaping. If they're sitting there talking to you in the clinic vaping and they're having playing with a cough, right? First thing I'm saying is, hey man, why are you vaping? This isn't helping. But think about that stuff that could cause, affect their cough. Then we look at acute. So 3 weeks is what we're going to go by. Some textbooks or some literature is going to say 8 weeks. The new hotness is subacute, which is at 3 to 8 weeks. And then you have your chronic, which is greater than 8 weeks. Secondary effects of coughing. Everybody here was around during COVID, right? When COVID first happened, what would happen if somebody coughed like in a public space? Ha! Typhoid Mary, and everybody would run away or look at them like they're just a crap human for going outside. How dare you with a cough? Right? So there are social effects. Like, I'll be honest, if I'm on an airplane and some dude's coughing next to me, I'm like, ah, crap, what's going on here? Or, you know, some of us have traveled to a lot of undeveloped nations. Where I was working in Africa, I was working with a NGO when I was in Uganda. We were kind of going all over the continent. We're going to go to this clinic, blah, 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 and then come to find out when I got there, it was a TB clinic. I was like, shit. All right, man, well, I don't have any PPE. I just got flip-flops and some cut-off shorts, so we'll deal with it. So think about all that stuff. All right, so you don't memorize this chart, but this is kind of an idea of some differential diagnosis. You guys are going to start clinical correlations in a few weeks. This is going to be a big portion of creating your differential diagnosis when that patient comes with a complaint. I apologize in advance, I'll be the instructor for one of your small groups. So common cold is going to be the most common for all this. But if we look through this list, what are on the top portion for acute? What are those that are emergent or like I need to no shit jump on if they come to the office? Yeah, I'm thinking about the stuff that's going to kill them, right? So right now, in this moment, if I don't do something, asthma exacerbation, 100%. Pneumonia, all right. Maybe if they're really, really sick and like they're not truly able to talk to me and like they just look unstable. Heart failure, right? That's probably been going on for a while. That's not rapid, but I need aggressive pulmonary embolism, definitely an emergency. Exacerbation, depending on how much it's actually exacerbated, could be. Anything else on there kind of stand out? Yeah, aspiration syndromes, especially if it's like an elderly patient somewhere like a nursing home who can't clear their airway, can't position themselves, they're kind of bed ridden. Think about that, and then that subacute is that post-infectious cough, which we're going to talk about. Right, so this is kind of a flow chart. Charts are great, right? But you guys haven't heard this, the term is medical textbooks come in black and white, patients come in shades of gray. So if you're trying to follow a flow chart, sometimes they just don't work for your patient. But that's why we have the art of medicine, that clinical aspect that we kind of figure out. So you can follow this down. Is it threatening, life-threatening or non-life-threatening? Those life-threatening ones are the ones we'd have to address first. And immediately, we're already doing that when we look at a patient. You're just determining are they stable, unstable, kind of that instinctive. If it's life-threatening, we're going to put them to the front of the list and start doing a good physical exam and start ordering appropriate tests. Non-life-threatening, take your time, do a little bit more in depth about your history of physical, and kind of go down those pathways. All right, acute cough viral going to be the number one thing you see in primary care. Everybody thinks they need what when they have a cough? Antibiotics. What specific antibiotic? personally treat antibiotics like narcotics, controlled substance, and I'm very conservative with them. The only time I'm not conservative is like deployment or austere environment, because stuff goes sideways very quickly. I have to evacuate somebody. Stateside, unless I have a very good reason or good cause, I don't just throw random antibiotics at it, because it's horrible for the patient, it's horrible for our population, and we're not developing antibiotics fast enough to overcome the resistance that we're getting from over-prescription defects. So, acute cough, viral, most common. Variable mucus production, systemic symptoms. If you auscultate, they're usually going to be clear. You may hear like some rattling, some bronchi, but if they cough or clear the throat, it usually resolves on its own. Now, chest X-ray. Do we get routine chest X-rays for every cough? Yeah, if you do that, you're gonna hate your life, because then you have more inbox to answer, more stuff to address, patients to call, and it's not really clinically indicated. And then radiology is going to be upset because you're that provider who's ordering 50 exams every day and backing them up. But if we are considering chest X-ray, these are the things that we're looking for. So respirations, if they're tachypnic, if they're actually febrile, if they're having a high pulse, or any indications of early bacterial infection. So, in our elderly, right, they maybe have that fever suppressed, it may not be happening right away. Check their mental status. So, if they come in with a caregiver, a spouse, their children, maybe you can pull them off to the side and say, hey, mom or dad acting normal, have they been a little off? That may be your early indication for the elderly. So consider that chest X-ray, acute cough, pop cold. And then treatment, right? We already talked about we're going to hold antibiotics because they're not indicated in this case. A lot of times this is going to be the difficult part of your encounter, is actually trying to talk the patient off a ledge that they don't need azithromycin, levaquin, or whatever, and that they just need to rest and over-the-counter meds and take care of themselves. And then anytime, any appointment, any patient, I don't care if it's for a PHA, just thing, this is one of those things in real life you always have to document some type of follow-up care or some type of symptoms worse. Now that you're active duty military, working in an MTF, you can be sued as well. So if you don't put that on there, you're wrong. So always have to schedule follow-up appropriately. For viral cough, you just say, hey, follow up in 5 to 7 days if it's not improving, or sooner if symptoms worsen. That'll cover you. So that subacute cough, that's that post-infectious, most common for 3 to 8 weeks. That's not to say that there's not other stuff, but most likely if they're otherwise asymptomatic, stable, you're not seeing anything that stands out, we're going to call that tussive syndrome. Anybody know what tussive stands for? Cough, right? So just cough syndrome. This is difficult to kind of reassure our patients that they don't need any more treatment or interventions this time. They just have to be patient. I applied to PA school. One of the general surgeons I worked with told me he did family medicine before he went to surgery. He said the thing about primary care, people don't want to hear, but 90% of the stuff that they come in, if you just leave them alone, it's going to go away on its own. There's a lot of reality to it, right? You don't have guys that come in, they're like, it hurts when I do this. I'm like, dude, what like, does your occupation require you to do the robot or something? Like, you break dancing in the motor pool? They're like, well, it just hurts when I do that. I was like, well, don't do it then. Sure enough, they stopped doing it, and it resolved, right? So the same thing with these coughs. If they're vaping or smoking, say, hey, man, this is just going to prolong it because you're destroying the cilia. You can't clear the secretions, and you're going to cough. All right, so now we're going to move on to chronic cough. This is greater than 8 weeks. Anything stand out as life-threatening right now? Aspiration, right? It could be a foreign body. It could be aspiration pneumonia. Yeah. Typically, that's not going to be the patient who just like sets an appointment 8 weeks out and is like, hey, I have a cough, and diagnose them with that. It may be tuberculosis, right? Somebody just came back from an appointment a few years ago. A country that's heavily affected with tuberculosis. Anything else? would say that carcinoma, so I've actually diagnosed 2 cancers in my career from chronic cough, where you start going down the pathway, you order a chest x-ray, there's something abnormal on that, then you send them to get a bronch, or you send them to get a CT, and then you're just like, hey, we're working this up, and then 2 weeks later, you call that guy in or that gal, and you're like, hey, I'm not diagnosing you with cancer, but this is highly suspicious of cancer, you need to go get this test. And that's a crappy conversation to have with somebody. All right, so chronic cough is going to be our 4 most common causes. So real world, you're going to see these questions. This type of thing is going to be on your pants. It's going to be on your pan ring. You're going to see other tests in IPAP, I promise you, like phase 2 or something. This is always a common question that they're going to ask you. What is the etiology of chronic cough? So kind of think above the lungs, right? Postnasal drip, above that upper airway. So the back of their throat, their nose, their mouth. In the lungs, is it pneumonia? Is it bronchitis? Is it bronchiectasis? It's a number of things. Below the lungs, so think stomach, or is that acidic contents coming up and then irritating the vocal cords? ACE inhibitor meds, right? So I think up to 20%, not 100%. You guys, have you done pharmacy yet? Right. Oh yeah? So what's the statistic for ACE inhibitor meds? What do you call it? What? 40? So other causes that are possible. Most infections, we already talked about that. That can go on for weeks and months. Those are very difficult patients to deal with, just because they're miserable, they can't sleep, they're having issues at work, they're missing work because they're coughing nonstop. There's not a great reason for it. Chronic bronchitis, the COPD patients. We'll talk more about that in the COPD. Anybody heard of non-asthmatic eosinophilic bronchitis? So it kind of gets lumped in with asthma because eosinophils, what do? Allergic reaction. Those white blood cells that respond to parasitic infections and allergies, right? So this is kind of that chronic cough without the tightening of the airway and increasing mucus production like asthma. Cancer, rare cause, occupational, environmental, right? You have a guy who's a fueler or somebody who works around aircraft and they're constantly around exhaust. They may be complaining about a chronic cough. Tobacco use. Right, so this you don't need to know this flow chart, but what we want to get out of here, there's kind of 2 options with these chronic coughs if you identify those 4 most common, right? Those 4 most common are at the top. You do a trial treat or a trial hold. That'll make more sense as we go along, but just remember that trial treat and trial hold. Postnasal drip, right? Most common cause in non-smokers. This is a hard one sometimes to sell to your patient because they're like, I don't have allergies. I don't have itchy eyes, I don't cough, I don't sneeze, I don't have anything like that. But you're like, hey, I think this is what you got based off of your symptoms and what you're describing. A lot of patients will be resistant to this because they're like, that's definitely not causing my cough. The way I explain it to my patient is if you hear like a dripping faucet at night in your bathroom that's 3 feet away from your bed, are you going to sleep? You're going to get annoyed, right? It's going to keep you up all night. So postnasal drip, if you imagine, is that drippy faucet that's trickling snot, mucus down in the back of your vocal cords. It's acidic. So what's going to happen with your cough? What are you doing? You're constantly trying to clear your throat, coughing, because it's an irritant. So that's kind of how I explain it to postnasal drip to these patients, how they're going to benefit. So signs and symptoms that may or may not have these: rhinorrhea, nasal congestion, throat clearing, voice changes. May find these physical exam findings, and been very lucky with finding cobblestoning in these patients, or majority of my patients don't have the best vision. But treatment, and this is that trial treat, right? So is it going to hurt the patient to do like a 2-week trial of some Flonase and some antihistamines, right? Minimal side effects. Say, hey, let's give this a trial, a few weeks, and let's see how you're improving. Typically, if it works, what happens? Patient never shows back up. So that's kind of the test right there. If they don't show back up, they don't like you, or the treatment worked, and they don't get to see you. I would say typically patients who get better don't follow up, right? Like just, all right, cool, let me see you again. So next is going to be asthma. So common complaint, especially like younger patients with mild asthma, is just going to be kind of a chronic, unspecific cough. You may see when they do exertional activities, which is like exercise-induced asthma. They may just say, hey, when I start running or I start doing anything exertional, I just start coughing a lot. I can't seem to catch my breath, maybe. If it's seasonal, there are allergies. It could be allergy-induced asthma. It may be, hey, as soon as I start that time of year, cedar comes out in Texas, cedar fever, I start coughing a lot, and that's their only symptom. So how do we diagnose that? So you do a Colleen Johnson for PFTs, right? And then we're going to see with that reversible. And what indicates reversible? What does that mean?
It's better with albuterol.
Give albuterol on their PFT after we do the baseline. What change are we looking for? What's that? All right, greater than 12% or 0.2 liters, right? That's how we're going to indicate if it's reversible obstruction or not. And then trial treatment. Typically, these, if you get them started on the right meds and you diagnose it, they have pretty significant improvement. Here's the thing I'm going to say about asthma, and I'll mention it again. This is kind of getting away from the medicine. In the military, until you have like a concrete diagnosis, don't put asthma in somebody's chart. And the reason I say that is that's going to generate an automatic medical evaluation for retention. Right? Every branch kind of has slightly different, but as soon as you put asthma in their medical charts, if they have to go to like SRP before they deploy, they're not going to deploy. Or we get screened by somebody else, it's going to go to the med board. So if they have asthma, by all means, diagnose them with asthma. But if they're coming in for their first appointment and you're ordering PFTs, don't put asthma as the diagnosis. Do that because then you're making a lot of work for yourself and you're kind of setting your patient up for failure. Right? So that's just kind of a soapbox that I learned the hard way when I was brand new PA. Chronic cough, GERD. This is another one kind of like postnasal drip. It doesn't make sense to patients why, if they have GERD, gastroesophageal reflux disorder, why they would have a cough associated with that. But it's kind of like the postnasal drip that I told you about. Is if patient lays down, that acidic content from their stomach comes up and it trickles over into their airway. Is that going to irritate their vocal cords? Right? Is it going to induce a cough, make them uncomfortable? So that's how I kind of explain these patients. You can talk to them about, hey, is this worse when you lay down? Like, they lay down at night, and as soon as they lay down, they start having coughing, and all throughout the night, they're not getting comfortable. They're like, oh, I think I have sleep apnea too. And you're like, no, man, you just have a cough. So talk about that. Do they have that water brash taste in the mornings? Does their mouth just taste disgusting? Talked about that stuff. And then treatment, it's going to be PPI, and it's dealer's choice of whatever's available. I would say omeprazole is most likely going to be the most common just because that's typically what all the treatment facilities have on formulary and it's very cheap. If that works, great. Nobody wants to be on a medication the rest of their life, so talk to them about the lifestyle changes that they can do to reduce their GERD. Which would be avoid triggers, fatty foods, caffeine, milk, caffeine, all that, chocolate before bed, alcohol. Stop smoking, right? Stop smoking. Lose weight if they're obese. Elevate head of bed. I don't see a lot of people doing that every once in a while. But you put you don't need to elevate it 45 degrees. I'm talking like 15 to 20 degrees. They put a few floats under the headboard and just elevate their bed. Some people that helps. I just don't see a lot of people doing that. So chronic cough, ACE inhibitors. Right? We've already briefly talked about that. 5 to 20% on the previous slides. Didn't know it was that high. Dry, non-productive cough, annoying tickle. The interesting thing about this is it's not necessarily right after they start the ACE. It could be months to years before they start to develop a cough. So don't say, hey, just because you've been on an ACE for 5 years, this is not the cause. It could be. So this is where you're going to do that trial hold, withhold medication for 1 month to determine if this is underlying cause. say that with common nuance is if the patient is blood pressure is like 180 over 90 or 100, maybe you don't want to do a trial hold, you just want to go ahead and switch into the ARB. So that's where that gray area comes in the ARB, right? If it's a young, healthy, otherwise asymptomatic, who just has mild hypertension, I may just withhold for 30 days. But if it's a 40 or 50-year-old that has comorbidities, I probably don't want to play around with that. And so I'm just going to switch into an ARB right away and call it a day. So that kind of that nuance depends on the patient. Shortness of breath, this is a very common complaint that's going to come in. Here we'll look at our differential diagnosis of things that could possibly be. If you look at the acute's a lot scarier than the chronic, right? As far as when the patient comes in there, I'm a lot more reassured when the patient says, hey, I've had dyspnea for 6 to 9 months, 12 months, versus somebody who just came in and otherwise healthy, who has no complaints, and they're just like, hey, I can't catch my breath today. Those are the ones that scare me. So there's acute, cardiovascular. Those are all something we need to address right now, or it's going to get worse. Pneumothorax. I can tell you at least 3 times at sick call or at the TMC where patients came in from PT, and they're like tall, thin guys. And they're just like, hey, I'm having some shortness of breath, and you can take a look at them, and they're maybe a little tachypnic, their vital signs are down, and they had a spontaneous pneumo. And they're just sitting there kind of talking to you. Like one guy we diagnosed with vaping in the waiting room. When we came out, we're like, you have a pneumothorax, you're on the ER right now. He said, oh, okay, cool. They're a young, healthy guy, even just otherwise stable. All right, shortness of breath, difficult or labored breathing, sensation not feeling lungs. While doing that right, you take a PT test, you weren't optimal that day, you have shortness of breath afterwards, so you're not in great shape. Important is to define the change in patient's activity level. So is it more concerning or less concerning because of a guy who's otherwise healthy, did a 10-mile run and you have to train for it and he comes in shortness of breath versus somebody who's like, hey man, I'm short of breath just walking up a flight of stairs, right? So kind of quantify that and say, hey, is this new or is some change? Are they training for Ranger school or to go to selection or some course? Make sure you look out for that. And again, down the thing, those red flags, cardiovascular stuff that's going to kill this patient if we don't intervene sooner than later. Dyspnea variations. So hyperventilation, it may not be a tachypnic patient. It may just be a patient that's taking 12 to 20 breaths a minute, but they're very deep. It just doesn't look right. They're constantly. Orthopenia, so shortness of breath while recumbent. So this is immediately upon laying down. See this a lot, like in pulmonary patients that are obese, right? As soon as they lay down, all that fat just basically falls on their chest and they can't get comfortable. It also indicates some cardiac disease too, CHF, congestive heart failure. Their heart's not very efficient, so there's a lot of fluid backup. And then the bottom one, the nocturnal, this is waking. So they fall asleep, they're fine, they're not having shortness of breath. And then halfway through the night, they just wake up suddenly, and they're very uncomfortable, and they can't catch their breath. So again, those last two, we're thinking cardiac related. So history, so this is kind of you're going to have one of these patients come in, right? This will be very helpful when you start clinical correlation. This is kind of the flow it's going to go. So history of present illness, right? What's another common way that we train medics and everybody to kind of look at something? OPQRST, right? So what's that stand for? Onset. What? Okay. Quality. Radiates. What else? Severity. Right. So some things it's not that OPQRST just doesn't really work for, right? High blood pressure. There's asymptomatic high blood pressure. Does that work for OPQRST? No, but for the most of this stuff, like you need to ask every patient if they're in pain. That's one of the first questions I ask is that fifth vital sign, and then kind of go down that path. So, are you having dyspnea at rest or exertion, right? Is this related to some exercise, some new event, or is it just you're sitting down and you can't catch your breath? Is it worse at night, lay down versus sitting up? Relative impact on activity level. It's an important question to ask. How has this changed your quality of life? Are you able to play with your kids? Are you unable to perform your duties in the military? Is this your first sergeant's now stressing you out because you failed your last 2 PT tests? You can't figure out why. Recent trauma, were they playing rugby? You know, the one thing I hated when I was active duty was like PT that was supposed to be fun, right? Or commander's call, like playing like flag football or like ultimate frisbee. The amount of like broken military officers I've seen that they're still like two that come out there, they're a little bigger, and then they tear their ACL from a frisbee. It's like, all right, man. But recent trauma, right? Were they doing combatives or something along those lines? Associated symptoms. Have you had this in the past? Right? If somebody says they have seasonal allergies, asthma very easily goes up high on my differential diagnosis because they're so closely related and closely mimic each other. Prior family medical history, do they have a family history of this? Have they ever been admitted to the hospital? Patients, typically, especially young, active duty, typically don't have like a great idea of past medical history because mom or dad took care of them to the doctor and have those conversations. So they may be an unreliable historian about their family medical history. Meds, all right, beta blockers, that's going to exacerbate asthma. So maybe they had very mild asthma that they didn't know about before, and then they got started on beta blockers, and all of a sudden that kind of threw it into a drive where now they're symptomatic with it. Allergies, social, so smokers. Also nowadays, you know, these slides are kind of medical textbooks of vaping, but definitely put vaping up high on there to see if that's an underlying cause. The physical exam, general, are they anxious right now? Are they sitting comfortably? Are they labored breathing? You see some patients that in the waiting room, and they're not trying to fool you, they're just calm because nobody's bothering them. And as soon as they come back, they get very anxious. They may have like white coat hypertension. So look at them in the waiting room or the treatment area, talk to your nurses, your medics, your MAs, your techs. Say, hey, this patient is looking like this the entire time. Go down there, ENT, right? Nasal polyps can be associated with asthma. Postnasal drip, JVD. If I see JVD, right, something bad's happening right now that needs to get moved up. Increased AP diameter, what's that associated with? Yeah, emphysema COPD patients. So when we say AP, it means the anterior posterior has gotten bigger. So typically, our chests are wider than they are deep, right? So increased AP diameter creates more of a barrel. Now the anterior to posterior versus the lateral are equalizing in size. Their lungs, you're going to listen to them if they have any of that. Cardio, they have liver enlargement. That could be push on the diaphragm, causing some breathing issues. And then look at their extremities. Have to take their shoes and socks off. They have like 1,000-pound or 1,000-pound sisters kind of feet, like that. Just budgie. Do they have edema? Do they have clubbing of their digits, which is another sign of COPD? So our level 1, there's going to be another chart so you can see this. This is your level 1 diagnostics for they come in there. EKG to rule out any type of cardiac cause for this. Chest X-ray, see if we see any nodules, we see any pneumonia, we see any widening of airways or any constriction of airways or consolidations. CBC, what's a complete blood count going to show us? What's that? So it shows the active infection. What else could it give us? Shows the anemia. It shows like early signs of some type of leukemia or cancer, or pancytopenia, where all their main blood lines are down. What about CMP? What's that showing us? Yeah, jump to metabolic, right? So that TSC, what's that going to use for? Thyroid, right? Hypo and hyperthyroidism cause shortness of breath by a number of mechanisms. So if you order all this and you're like, man, it's still not coming back, diagnosis is not evident, you go down to level 2 diagnostics. You don't necessarily order all of these at once. If you did it, this is like a $10,000 workup right here. We're going to look at crazy if it's just borderline decent symptomatic 19-year-old, you order everything on there, but do what's appropriate. So if it's just some young, healthy adult that comes in and they have no red flags, maybe just PFTs. If it's somebody older, like a smoker with comorbidities, I'm probably going to be more aggressive and take CT to rule out some type of carcinoma. And if that's still not evident, you can refer out. And then depending on where you're at, it's kind of go like Fort Polk where there's nothing around there. You may have to get creative with your consults. If you're at a bigger treatment facility like BAMC or Womack or Fort Bragg or San Diego, the Naval Center there, then you can get into pulmonary. Otherwise, you have an allergy or internal medicine. Just another flow chart, kind of an idea of how you do it. On the right, you're going to see those level 1, level 2, level 3. I've never ordered a bronchoscopy as primary care. Typically, you send that to pulmonary, and then they're going to make that decision if they're going to do bronchoscopy or not. All right, coughing up blood. Like I said earlier, the majority of the time, this is not true coughing up blood. It's that pseudo down at the bottom from something else. But if it's true coughing up blood, we have to rule that out. So the most common is going to be bronchitis. That's just that frequent coughing, irritating the airways, and then you get some of those capillaries leaking, and you get that blood-tinged sputum. Infection, I think TB, right? You ever see Tombstone? Doc Holliday, he's always coughing up blood, and he's got like a bloody soaked handkerchief. Carcinoma, right? If somebody's a smoker and they come in with coughing up blood, very quickly I'm thinking it's carcinoma until proven otherwise. It get very scary with smokers who come in for this kind of stuff. Vascular PE, may or may not. Pulmonary edema, so it's going to be that pink tinge frothy sputum. It's very bubbly. You'll probably see that in some of your like ICU rotations in patient. When you go to suction them out, it comes out and it's very pink and it's frothy. But more common, it's going to be this. It's going to be something else, right? Like a guy bites his tongue on an airborne operation before he lands, and he comes up, and the medic's like, "Oh, he's coughing up blood," and then you look, and he's bit part of his tongue off, or he bit into it very well. Car wreck, it's very common for them to bite down, but it's usually like that, or nosebleed, right? Posterior nosebleed or anterior. So it's rarely actual blood in their airway. Really what to get out of this is that bottom box right there. Do a good history and physical. Majority of time, if you do a good detailed physical, like actually open up their mouth, look in there, put your gloves on, feel around, you may find some type of bleed, or if it's coming from their nose, it's pretty easy and diagnostic of what it is. Just swallow propane will be the last thing to cover in this class. Vast majority of the time, this is going to be caused by what? Some type of trauma or overuse syndrome, right? They may tear the muscles, the intercostal muscles between your ribs, very painful. We've had a few times from guys that think they're CrossFit level like expert, and then they go in there and they start swinging 80-pound kettlebells, and it doesn't go well. Guys who haven't done like a pull-up in 20 years go up there, they maybe gain 50 pounds since they went to airborne school. Not pointing to myself. Pleural effect, right? So think about their history with this. Can they non-specific? So if you press on their chest, are they able to reproduce it? That pleural pain, you can't really necessarily reproduce it. But if you can localize it, that helps you out with your chest x-ray. If you just send a patient for a chest x-ray and you say rib pain, doesn't really help out the radiologist. But if you can say right, fifth rib, pain along, localized, then they're going to do a better job of getting a report and looking at it. Diaphragm, refer to the shoulder. If you get pancreas or liver disease, say that's less common as far as chest wall, early pain, but you are going to see it. Mediastinum, what could that be? Like right here on the sternum, if I press down, like I rub. osteochondritis, if you guys heard that term. Basically inflammation of the cartilage around the sternum. I always see that classic as like promotions in the military. What do people like to do afterwards? In the chest, right? You guys ever see that video in Afghanistan of the soldier getting promoted and they hit him with the hammer? So I inherited that patient later on, and that guy was screwed. I had to med board him. So they took a big mallet and they thought they were being funny and they just hit him as hard as they could in the chest. They actually cracked his sternum, and they separated some ribs from it. That guy had to get like his sternum rewired, chronic pain syndrome. That guy was a mess. He was a really nice guy. It was sad was he was actually getting promoted, moving up, and then leadership thought it was cool to do that, and they ended that guy's career. He's still in a lot of pain to deal with it. So, chest wall portal pain, not actual chest pain, I mean not actual lung tissue, but it's something outside of that, either the muscles, the fibers, or the bones. All right, any questions about the pulse? All right, let's take 5 minutes, and then we'll start the next one.
You know what we need to do?
Well, I am curious about getting matched. I thought all this time I was being matched 5%, but apparently the trade-off is that I get like in my pension retirement is more without.
Stiff arm.
Yeah, I mean that's probably why yours is like also insane.
Unfortunately.
I'm excited once as soon as we start doing once we start taking the kids' funds out of their CDs and put them into these like into an S&P 500 or like the other investment things. I'm excited to see how it does. See what happens.
It's all like, I guess what you do now.
Was it yesterday? It was in two places. Jay gave it. He did. I want the bug to be named. That's how much I want.
I've been figuring this. We want to make I'm gonna try to say this so successful. We get out early, ran on it. First one, ortho. It feels pulmonary. You can always make, I feel like, if you want to call me, I'm down to know. Especially if you get like water and I switch not right.
Highly.
He's got that thing. You know what I really like and I look forward to? I've only used it once in a field training exercise, but for Christmas one year, we got me a jet oil, my first jet oil. You can either buy one or my French press works perfectly. It fits on it. It's made to. And so, French press, I can imagine French press coffee or for me, I but that's what that made me think of. It's like portable.
Next class, other airway disorders not have the COPD. So there's a few in here that you're going to commonly see as well, kind of fall into what we talked about earlier, that generic term of upper respiratory infection. Not other airway disorders, not asthma or COPD. Foreign body aspiration, who are we thinking?
Kids.
Kids, right? Can it happen to adults?
Yes.
Yeah. We used to work for a pulmonologist in Augusta, Georgia, a university hospital. And he was Dr. Everly. He had a mullet. And he used to smoke Marlboro Reds. I can't make this up. He would, like, when you see him off duty, he'd be wearing like jean cutoff shorts. But he was a very smart guy. And he had, like, in his office, on his windowsill, he had things that he had removed from people's lungs via bronchoscopy. Pretty impressive, like, stuff. Toys, money. One of them was a gold tooth. The guy gave him the gold tooth as a gift for thank you for saving his life. The guy got in a fight, knocked out his tooth, and then it went in his lungs. So foreign body aspiration can be just about anything. But for the most part, we're talking about kids. So potentially life-threatening. If it goes down to smaller airways, a little less life-threatening, but we still need to worry about it because that can very easily turn into pneumonia or cause some other issues. So if it's in toddlers, food items is going to be more common, right? That's when they're learning to eat. You're giving them little trial samples of stuff. Older children, typically it's going to be the non-food items, the more exotic stuff. Did you guys see that article about the kid in New Zealand? Remember those little magnets that you can link together, like the little things? The kid swallowed 100 of those. Got up off this like Chinese website and got him sent to his house, let his parents know, and I don't know why he swallowed 100. Maybe then one was good and two was great, and then he said not going all for it. So depending on the location of that, is kind of how your patient would think, right? Your classic triad is cost. When it initially goes down past the vocal cords, then stridor wheezing if it's in the upper, right? It's blocking part of that airway, so you're having a little bit increased work of breathing and diminished breath sounds. Reflexive tachypnea. Anybody know what that is? Yeah, so it's your body's kind of instinct to naturally increase. So what it is very distinct. It's rhythmic, shallow breathing that's very fast, right? That's kind of you're not doing that. Your body's instinctively doing that. It's saying either you have too much CO2, you don't have enough oxygen, so now your body's doing that. So that's going to follow that initial triad right there. And then depending on how far the foreign body goes down, the symptoms are going to change, right? If it stays in the upper airway, you're going to have stridor because it's including part of the trachea. They can't get moved. They're going to be in respiratory distress, right? Very evident. Middle airway, right? So is this upper airway, lower airway, or middle airway? This picture. Yeah. So it's right main stem, right? Why would it go to the right main stem? So straight, wider, more vertical, right? I've already talked to you about that. And then lower airway, small bronchial, so it's a very small, like a Lego piece or something. They swallow that, they have that initial cough, a little bit of wheezing, discomfort, then it goes down there. A lot of times, it may be asymptomatic at that point. But if you witness it, that doesn't mean it's going to come out on its own. It still needs to be evaluated, right? So you'll get parents that'll bring their kid into the ER and they're like, I swear I watched it, blah, blah, blah. You get initial chest x-ray and it doesn't show up. You're like, hey, it's not, but if it's witnessed, then you're going to go further. We'll talk about that. This is from up to date. So if you look on the left, right, suspected or known for body aspiration. You put something down, and you look at your kid, it's gone, and they're coughing and wheezing. That may not have been known for body, but I'm definitely suspecting it, right? So is it asymptomatic or symptomatic? Symptomatic, stop what you're doing, it's BLS. We're going to do chest slaps, back slaps, and chest compressions for an infant. If they're older, we're going to start trying to do the Heimlich maneuver. If it's asymptomatic, then we kind of go down there, we can slow down. First thing you're going to do is plain film x-ray. That may not show up if it's like plastic, wood, or some piece of glass. But if high end is suspicion, you can still keep going, and then that would be where you order the CT, because everything's going to be found in CT. Now, if you're like at a bigger hospital or a teaching hospital, they may have pulmonary available. So they may not want to sedate that child right away into a CT. So you can say, hey, the parents witness this pulmonary may come down and do a bronch if that's available to you. Typically, you're going to get the chest X-ray and go down to the CT before you call it. So this is when the patient is stable. So if they're unstable, what are we doing? BLS, right? We're doing those Heimlich maneuver or chest compressions or back slaps. If they're stable, this is how we're going to start going down. Moderate high suspicion, witness. We're going to get a physical exam, plain neck and chest X-rays. And then if it's still not showing up and the parents are saying, hey, I swear I saw it, then you're going to add that CT. Low suspicion if they're asymptomatic and questionable by history, you get X-rays and then have them follow up. But again, you have to think about something 2 or 3 times. My personal opinion is go ahead and do it, right? If you're going to sit there the rest of your shift and be worrying about it, probably means you should have done it initially. Radiology is never going to get upset with you if you go ahead and order a CT for questionable or suspected aspirated object. So here's some examples of those. So if you look on that left upper corner, what that's showing you is the airway. They're more prone for it to be stuck right there because it's more of a funnel versus adult airways are more like a cylinder. Let me see over here. What is this most likely? On the right upper picture. That's a coin. So if that kid comes in there, do you think they're symptomatic, asymptomatic? If it's up there, right there, they're very symptomatic. I'm not 100% sure what's going on with this chest X-ray either. Over here as well. They may have been there for a while and they're just now getting to the chest X-ray. What about this down here? A piece of electronics or something? Not 100% sure. Maybe like a keychain. And then right here, where do we think this is stuck in? The right main stem, right? So if that's including the majority of the right main stem, what could that induce? Right? They're going to start to see atelectasis on the right side, the alveoli collapsing because there's no air going in there. That left lung is having to overwork or causing some issues. You don't have to memorize this. This is just from the American Academy of Pediatricians. I'm sure Major Klein will go more in depth with you about this, about pediatric stuff. But these are general precautions. I feel like my parents never did any of this. I was the 5th child by that time. They're like, we already have 4. If this one doesn't make it, it's all right. It's a 9-year difference. So I feel like they were just like, all right, we're going to see what, we're going to do nothing this time and do a trial and just see how he does. All right, so I'm going to tie this. This one scares me. In the first picture, you're going to see why. So epiglottis, right? What does epiglottis do? So when you swallow or drink, right, it folds down kind of like to block the tracheus so nothing goes in there. Now, that's just your anatomy, right? Now look at this picture up here. On the left, what you're seeing is a normal healthy airway. What's on the right? That's completely just going right there. This may be a bougie. This may be a maybe an ET tube. May have been they put some other type of tube down because the ET tube wouldn't fit, but most likely this is a non-cuffed ET tube for pediatric patients. So, like we talked about with BLS or PALS, right, Pediatric Advanced Life Support, you don't have time to, with kids, to sit around and kind of watch them to see how they're going to do. They compensate to what? They crash and they can't compensate anymore. So you have to be aggressive with these kids and have a high suspicion of what's going on. So, inflammation of the epiglottis, see this kid, what's going on with this kid, what do we look like? The other kind of like in that sniffing position, a tripod, they're trying to catch their breath, trying to get air in and out, trying to find a comfortable position. One of those things is always let your patients, if they're trying to sit up or trying to get comfortable, let them, right? Previously, I've taught it in some trauma courses. What does everybody try to do when the patient's sitting up and they're like pulling blood? They're like, lay down, and they're like, just relax, and they're gurgling. And then the medic or the provider is just like, no, lay down, it's all right, I got you. And they're like, no, man, you don't got shit. Like, I'm drowning right here. So don't fight your patients. If they're comfortable, let them get comfortable, okay? So, everybody keep track. Staph, those are going to be your most common causes for this. Used to be influenza type B until we started vaccinating. I'm not saying this isn't a political thing by any means, don't take it that way, but we're starting to see an increase in certain states without immunization, so this may change. This is where you kind of keep up with what's going on in the world, because what are we having outbreaks in Texas and South Carolina? Measles, right? We're going to like the back to the Oregon Trail where Mary Magdalene and Sam died of dysentery, and Mom died when you drowned the river or tried to cross the river, and it didn't work out, right? Then you killed 4 buffalo and you killed 3 elk and you brought 12 pounds of meat back to the camp. Right? Some of you guys don't get that reference. Some of you poor guys do. So clinical presentation is very important with these patients. They're going to come in, they're going to be in distress. So it's that tripod or sitting position. Tripod meaning they're kind of leaning over, their arms down. That sniffing is they kind of got their nose out like they're sniffing something. And then stridor, the muffled hoarse hot potato voice. Anybody know what hot potato voice sounds like? So they describe it as somebody who has a hot potato in their mouth. They can't really make clear sentences, kind of hoarse. But imagine somebody has a hot potato. You can go on YouTube and watch videos of people talking. I always find it funny on these videos too. It's like some ER doctor videotaping the patient wanting them to talk so that they can show everybody the patient just like obviously like, I don't want to talk right now, man. I feel like shit. And the guy's like, just say these words. And the patient just wants to be treated. But yeah. The tripod position is that stridor, fever, sore throat, tenderness. But again, watch out for those red flags right there. Stridor, intercostal retraction, tachypnea, cyanosis. What's that indicating? What are they going to be soon in if we don't get involved? They're going to get respiratory failure, right? Right now they're in respiratory distress if they're sitting there talking to you. But if they stop talking and then they start using their intercostal muscles, accessory muscles, and they start really having labored breathing, they're soon to be in respiratory failure. So this is kind of the diagnosis right here. The gold standard is direct visualization, laryngoscopy. So you take that laryngoscope, you open up the airway, and you see that the epiglottis is inflamed. But the first thing we say is use caution. Stimulating even a mildly inflamed may induce rapid swelling. So this is something you do in an outpatient clinic, something you do in urgent care. No, like if you have this, don't sit there and like, all right, I'm going to show the medics what this looks like. This is going to go bad, right? So typically, if they're in the ER and they're to this point where they're looking at it, they have their airway card out and everything ready to go in case this does happen. So if you're thinking this, don't sit there in the outpatient clinic trying to evaluate the patient and keep working them up. Call 911 or call the ER and say, hey, I'm transferring a patient to you, this provider so-and-so. These are the following signs and symptoms, blah, blah, blah. Here's the thing, they can't with future patients, so don't ever let them push you around. Be like, cool story, you're not taking the patient, I'm still sending them to deal with it. This needs to go to the ER. X-rays, this is kind of bad mnemonic for epiglottitis. I guarantee you're going to see this later on. You don't need to know what it looks like, but you need to know if they say, hey, there's a thumbprint on the neck X-ray, you need to know that that goes with epiglottitis, right? Bob Cole may show you that one too. But we're going to maintain our airway, supplemental oxygen, antibiotics, maybe that third generation. This is what it looks like. So, you guys can see, got a positive arrow sign, right? The radiologist was nice to us. There's epiglottitis when it's normal, and this is what it looks like, that thumb sign. So imagine that, right? So you don't need that X-ray to make the diagnosis. Again, it's direct visualization. They may use a bronchoscopy or something like that to visualize it as well in a bigger hospital. Croup. So a little less scary. Anybody have kids that have croup? Sucks, right? What do you remember about it?
Cough forever.
What kind of cough?
Seal like at night.
Still like that barking cough?
6 months after it's done.
It's like a cereal, right? It's very annoying, but it is not as bad as epiglottitis. So children 3 to 6 months, or 3 years old, 6 months to 3 years old. typically in the fall and winter. Why is that? The flu season, right? You're going to see this commonly, like daycares, babysitters, playgrounds, stuff like that, schools. It affects the larynx and the subglottic airway. So very distinct about this is that barking cough, right? So if you ever get a question on a PANS, phase 2 test, pan rate, whatever, and they're saying, hey, child, barking cough, what do you need to think? Croup, right? Very specific for this. So they take the cause of barking cough, typically they tell you barking cough, try and get it croup. They may have hoarseness too. So the nuances, this happens very quickly. They represent as, hey, the kids had for like a day or two, some cold symptoms, and now they got the barking cough that's very distinct, and that's going to happen over a matter of 2 days. Again, steeple sign, this is very something specific about croup. You don't need to be able to interpret it, you just need to know that steeple sign is indicative of croup. So can everybody see that? Look on the right here, this is the trachea, and then it comes up to where it's almost pinching here. So the crino would be right here. These are your lungs, right? Same thing over here. This is the trachea. So typically self-limited, mild to moderate, you can give a dose of steroids. That'll help with some of the inflammation and some of the symptoms. Moderate to severe, if that kid is starting to use accessory muscles, or they're starting to look labored breathing, or they're not getting comfortable, what are we thinking? If they're going into respiratory failure, we need to get them somewhere where they could maintain their airway. So they need to go to the ER sooner than later. That's a big thing you need to counsel the parents on when you have one of these kiddos. Hey, if they develop any of these red flags, and go for the red flags, maybe write it up and say, hey, if they develop any of these, you need to go to the closest ER. The big thing to counsel them on is day 2, typically when they're going to present, because that first day is just URI symptoms, like a cold. Day 3 or 4, it's going to get worse, right? So just tell them, hey, the coughing is probably likely going to get worse over day 3 to 4. Not necessarily need to be concerned about. These other things are what I'm concerned about. So if they develop these other symptoms, please come back. But if they're just coughing for 3 to 4 days, I'm less concerned. Acute bronchitis. This will be falls again under that kind of URI cough, non-specific. This is going to be one of the most common diagnoses that you make in primary care as well, especially that cold and flu season. All right, Dave Chappelle, what's this character's name on the Chappelle show? There you go. All right, that's going to be on the test too, for sure. If you don't get that, man, I'm done with all of you guys. So acute bronchitis definition, lower respiratory tract infection, large airways of bronchi without evidence of pneumonia. So a lot of times you're going to get to that patient and you're like, this don't look well, and you're going to kind of go down 2 pathways after you get to your differential diagnosis. You're going to go pneumonia or acute bronchitis. And they mimic each other in a lot of ways, and they're going to look similar. But acute bronchitis is usually less severe of flu. Pneumonia is going to be significantly more symptomatic. The patient's going to look worse. But cough plus or minus sputum. Say with acute bronchitis, typically you do have sputum. It's usually productive. Pneumonia may be productive, but it's usually less productive. So again, what's the difference between acute bronchitis and pneumonia? Like just as far as the underlying, what's going on with pneumonia versus bronchitis? So bronchitis can be an infection, right? It can be viral. But this is affecting, the alveoli. So acute bronchitis, just think of the word bronchitis, right? It's the bronchi and it's inflamed. So this is the bronchitis, right? Pneumonia is going to be the alveoli, and it's going to be an infection as well too. So go down there, prolonged coughing, bronchi, that's that kind of that rumbling sound in their chest that you'll be listening to them, and then they'll cough, and then that sound will go away. They may or may not have a fever. Typically, with acute bronchitis in a young, healthy adult, they're not going to have a fever. They're just going to look kind of down and like crap. Typically, a clinical diagnosis. So if you're concerned about pneumonia, if they have a fever or it doesn't add up, kind of your spidey senses, go ahead and get a chest X-ray. And what will we see on a chest X-ray with pneumonia? Some type of consolidation, most likely, right? But again, this is where the patients, every one of these patients comes into urgent care wanting a Z-Pack. And then when you don't have a Z-Pack for them, they leave angry, they file a complaint, give you an ICE complaint. So some of you guys with common names, when it comes to ICE complaints, you're gonna get screwed. When it's me, no one knows how to spell my name or say it, so they never can find me on Outlook, which is nice. So, or if they spelled it incorrectly, I just don't respond. Like, that's clearly not me. But self-limited, you don't need antibiotics. Educated, you can help manage the cough, right? So this is where that art of medicine comes in. If the patient's about to go TDY or go on something, you may want to give them some type of costopressor or something like that, just so they can get on an airplane and they don't get held up in Ethiopia because they may have COVID and they don't want them on the airplane or something like that. So use your best judgment when it comes to these patients. Bronchiolitis. Put RSV because that is by far the most common cause of bronchiolitis. So without going into what do we think bronchiolitis is? So it's the smaller airways, the bronchioles versus the bronchi, right? Bronchi are going to be those two main that come off the trachea, and the bronchioles are the smaller airways that lead to the alveoli. So RSV is most common. Who here has kids? What happens when, like, one kid at school or daycare gets RSV? Everybody does it, and then people have to start missing work because the place shuts down. I feel like the daycare on Fort Sam is constantly in the winter sending out alerts that they're closing for the day to come pick up your kids because somebody got RSV. So again, there is a vaccine for this. Effective for adults and children. But clinical presentation, wheezing, dyspnea, forceful cough. Not 100%, but a lot of times they're going to have electric mucus, where this is because that kid's coughing so much, it's busting his little capillaries or causing irritation to the airway. May have low-grade fevers, typically a clinical diagnosis. How you're going to diagnose this is going to be that rapid RSV, right? So that's not a fun test to do on kids because you have to saturate their nose, the nasal wash, and then you have to suction it back up and run it. Most kids just don't like it or tolerate it, especially little ones. Self-limited, 7 to 10 days, really needs admission. I'd say it depends on where you are at, if they're going to get admitted or not. When I was at Fort Hood as a RT back in the day, we had one pediatrician that would admit every RSV kid, which sucked because then every other kid on the ward got RSV too. The nurses would beg her not to. But if they're stable otherwise, they can be sent home and just strict precautions if it worsens to come back sooner than later. Cystic fibrosis. So treat a few of these. They're very intense like patients because it's a multidisciplinary team that will take care of cystic fibrosis kids. So it's going to be pulmonary is going to be involved. Typically dietitian, nutrition is going to be involved. Developmental pediatrician is going to be involved with these kids. It's the most common fatal hereditary disease of Caucasians in the U.S. So this is a recessive disorder, meaning both parents have to be carriers of the trait for the kid to have the actual cystic fibrosis. A carrier, one parent, and they can pass that on. But if both parents are carriers of this autosomal recessive gene, it's 1 out of the 4 kids is going to likely have cystic fibrosis. 1 and 2 is going to be a carrier of that. If one parent has the recessive gene, then it's 1 in 4 kids are going to be a carrier, right? And I don't mean this to be funny. I've taken care of quite a few of these. We had neighbors living on an Army installation at Fort Knox when I was little, and they had 5 kids, and the youngest was the only one without cystic fibrosis. So kind of sad. They had one and they just kept having them, and they were very nice people, but yeah, the only one that's alive is the youngest kid now. They've all since passed away. Kind of sad, but I will say with cystic fibrosis in general right now, it's actually an optimistic time for that disease because the age keeps going up as far as life expectancy. If you looked at the 1950s, 60s, these kids didn't make it out of elementary school. Now the newest numbers, the predictions that they're looking at, children born between 2020 and 2025 with cystic fibrosis, their life expectancy is now 65 years old, which 20 years ago, nobody would have said that, right? So it's pretty crazy how well they've gotten at managing this disorder. Clinical presentation. This is typically, you're not going to diagnose this as an adult. This is almost always going to be a child. It's going to be very early on that they're going to notice that this kid, especially as a baby, they're going to be like failure to thrive. They're going to be undersized, constant colds and infections. That's kind of what threw you in. So, cough with a heavy sputum. Why it's heavy is this, okay, that chloride transport. So, they have a defect in that gene that is not allowing less sun chloride. So, it means less water is following. So, it's very thick, tenacious secretions. And it's not just pulmonary, it's going to affect their pancreas. So, they're going to have dietary issues, they're going to have metabolism issues. Salty skin. So what does that mean? The patient comes in and you got to lick the side of their face. I've had people tell me that before, but salty skin. So that's their sweat, but they're not able to reabsorb that salt, so they have excess salt on their skin. That's going to be important, especially when we talk about how you diagnose them. So that chest X-ray, a few things that kind of stand out to me, right? It's hyperinflated. What else do you see besides, if we look past the lungs, what else are we seeing on this chest X-ray? It's very obvious. What are you doing there?
It's like the S.
So what does this indicate? Scoliosis, right? That has nothing to do with our diagnosis or class, but you see that chest X-ray, hopefully you pick it up, right? But what I'm seeing about these are the hyperinflation that's widened, and then you see these right here. These are dilated bronchioles from all that mucus production right here. Over here, you see like a big plug, some of this right here. So that's going to be a chest X-ray cystic fibrosis. Respiratory acidosis. What's respiratory acidosis numbers-wise? So what's going on with the pH first? pH is low, so it's acidic, right? And then what does Rome stand for? So it's respiratory acidosis. What does that mean? What's going on with the CO2? It's high, right? So that's driving it down. Now these are chronic patients, right? This isn't just something that they have. So they're going to have chronic respiratory acidosis with renal compensation, right? It means that kidneys, which usually take what, like days to weeks to kick in, they're in a constant compensation type mechanism right here. But they're not able to ventilate because of all that mucus, right? They're not able to clear it, so it's affecting their alveoli, but it's also affecting their upper airway or their bronchioles. So that's why we have that PFT mixed, right? So what would indicate obstruction on a PFT? What numbers? FEV1 and what else? Yeah, the ratio. So what would be obstructive? Less than the lower limits of normal, right? 70 is COPD. What about the restrictive? What number? So what on the PFT, which one is that? That tells if it's restrictive. On your shirt. Forced vital capacity, FVC, right? So that FVC is decreased because they're not able to get a deep breath in because they have all that mucus in there and they're not able to completely inflate their chest. What's going to be diagnostic of these is that sweat chloride test. You're going to see this. I've taken the PANS now once and the PAN-RE 3 times. PAN-RE is the test you take after you pass your PANS. You do it like every 5 whatever years. Every time I've taken one of those tests, this question has been on there. Is going to be, how do you make the diagnosis of cystic fibrosis? They're not going to tell you if the patient has cystic fibrosis. They're going to paint a picture of the patient has heavy secretions. They're unable to clear. They are smaller than the average child their age. They're Caucasian. They're at this age. Failure to thrive. They constantly or frequently get infections or are hospitalized for pneumonia or cough, stuff like that. And the answer is going to be sweat chloride test. So what that is they actually apply their carpine right here. They're going to actually apply that and then put electrodes on top of it, penetrate the skin, and then when it comes out, they're going to wipe it off with a rag and measure those what they wiped off. So that's going to be your diagnosis over 2 days. But a normal test does not exclude cystic fibrosis either. So treatment goals, early recognition, referral. Typically, these aren't captured later on in life. They're caught like infancy, elementary age at the latest. These are difficult patients because it's very time inclusive, right? So anybody ever heard of CPT, chest physiotherapy? So that's where you like beat on somebody. Might have a demonstration. So chest physiotherapy, back in the day, we used to do it by hand to turn around. I would lay the patient in different positions and I would cup like this to actually loosen up the secretions so they can cough them up. Now you can sit down. I appreciate it. Sorry for you. They also have like vests that you put on that are pneumatic that basically just shakes the kid and rumbles them up. You're trying to loosen those secretions. They'll also nebulize before that with some mucus thinners, mucimist, to help loosen up the secretions. This is something they have to do throughout the day multiple times. What happens when they get teenagers? What do teenagers do? They're like, I'm not doing this, right? They don't want to listen to mom or dad. They don't want to listen to doctors. So if they become teenagers, it becomes a little bit more difficult to treat them because nobody wants to live their life this way, right? You have to do this every day of your life 4 or 5 times. It becomes difficult. But they need to be very dedicated to that, to the secretions, vaccinations, so they don't get secondary infections that can be detrimental to these patients. They're going to need follow-up nutrition because they're going to have failure to thrive because it's affecting their pancreas, their stomach, and other key things. So average lifespan right now is 44, but plenty of documented patients. Those patients are in their 60s and 70s, and if you look at the chart of the time, like I said, in the 50s, the average age was 2 years old. 60s, it was 10 years old. Now they're predicting the next generation is going to be 65 years plus, which is pretty awesome. And a lot of the bigger hospitals, you go to maybe like Tripler in Hawaii, Madigan, KMC, they're going to have like pediatric pulmonologists that are dedicated to this. If you're at a smaller installation, you're taking care of kids, you may have to send them out on the civilian side to a local medical center that has these specialties. All right, next, I think the final one is going to be bronchiectasis. This is going to be like the differential we talked about earlier. The most common, least common, less common, zebras. This will probably be in that less common. This isn't going to be high on my differential diagnosis, but you are going to see it from time to time. So it's kind of, this makes it a little tricky right here, is it's widening of the airway, but what is COPD and asthma? Constriction of the airway, right? But these will mimic COPD and asthma patients. So kind of you can think about the disease pattern here is somebody gets sick, right? They get some type of respiratory infection. That affects their airway, damages their cilia, right? They get scarring on it, which now widens their airway, makes them more prone for mucus pooling. All that mucus builds up in their airway. That's what you're seeing on these pictures right here. The left one is a normal, the right is abnormal. That clear spot right there, that's the actual open portion of the airway. The rest of this light blue is that mucus pooling. So it's kind of, it feeds into itself. So person gets sick, this happens to their lungs, mucus builds up. Mucus that's not clearing has bacteria in it, leads them to increased pneumonia, the risk of infection, which gives them another infection, which now damages their airway even more, the cilia. Without the cilia, what can we do without the cilia? Right, we can't effectively clear the secretion, so you see how this is kind of a negative loop right here, it just keeps feeding into itself. But it can be caused by a number of things. So cystic fibrosis is common in those kids, rheumatic disease, aspergillus, aspirations. It's fixed dilation, so once it starts dilating and damaging, it doesn't go back. This is not typically seen until they're about 6 years old, and it's more common in women. So, cough, daily sputum. This is going to be, what else? I think cough and daily sputum, what other conditions? COPD maybe? Chronic bronchitis? Right, that's a very hallmark sign and symptom of those patients as well, too. So when you first see these patients, you may say, hey, I think you have chronic bronchitis, and you start going down the treatment pipeline, and it's going to kind of split and go from there. So diagnosis, treat underlying cause if it's aspergillus or some type of infection. typically when you get that CT, that definitive study, and I'll show you here in a second what that looks like, it has very pathognomonic like findings that you're going to see on CT and chest X-ray, which are those tram racks and signet rings. So again, I don't need you to know what they necessarily look like for testing purposes, but I need you to know that if you see those, this is the diagnosis. What do you think you would see on a PFT with this patient? Would it be obstructive, restrictive, mixed? Why do you think obstructive? What's that? Obstructive, could it be mixed? Right, if they have increased mucus and they're not able to clear it, are they able to take a deep breath? We say obstructive, but it can also be a mixed as well too. So you think about it, you get it back, this was an advanced disease, like this has been going on for years and years and it's diagnosed and treated. Very well at that point can be restricted as well. And avoid cough suppressants, right? We want these people to get all that sputum out, and to do that, we may actually give them some eucalyptics. Eucalyptus, they may have to go home with a nebulizer so that they can nebulize that, and that's going to help open up the secretions and help make them easier to clear. So, yep.
So if this is irreversible, does that mean the patient has to be on medication for life?
That's a good question. So PFT, we see obstruction, we do what? What test? Reversibility, right? We give them some albuterol. And then if it's reversible, what's our diagnosis? Asthma. If it's not reversible, what do we think? COPD or some other type of disease, because this is not going to be responsive to albuterol. That's why you see under here other therapies, less well-studied bronchodilators. I mean, I don't think it's going to hurt the patient, but it's not really necessarily indicated because the bigger problem is the mucus production in their airway. And then here is that tram tracks, so think like train tracks, right? That's the actual bronchioles. That's the fibrosis in that right here. You see the same thing over here. This is a cross section. Right here, we're seeing that. These are the bronchioles right here. And they have all that scar tissue on them. They're widening up like that. So you see it, not so clear on that x-ray, it's not a very good one, but it's very clear. See how dilated those are? Should be about like a fifth of the size of that. All right, any questions about any of this other stuff? All right.
One thing, so everybody takes it off.